thank you.
My apologies. Go ahead.
Thank you all for making the time and joining us tonight. We're really looking forward to this session and looking forward to learning together. We know that this has been a really difficult time for many people. The vaccines are exciting, but also a little bit confusing. We understand that. And that's why we really wanted to come together tonight to really offer our support, offer knowledge, information that will help you through these next few months as we hope each of you have the opportunity to get the vaccine. I would like to also thank Naseem and Sarah and Brenda for organizing this event, because this wouldn't have been possible without their hard work and coming together and putting this together. So I'm really looking forward to an evening of learning together.
And I'll just jump in for 1 minute so that we can get onto the main attraction and say hello to everyone. It's so lovely to gather with a community. I almost felt like this was a Cineplex opportunity. This is a big ticket, sold out in 90 minutes. So we're really happy that you all joined us. I want to thank our panelists as well. I also would like to thank our Patient Family Advisory Council and all of the patients that have been giving us feedback all the time, but during the pandemic, you have been giving us feedback in our patient experience survey, and it's really helped us to hopefully know how we might be able to reach out to all of you. We don't have all of the answers about the how-tos tonight, but we will actually answer as much. And we just wanted to say that after this talk, we will all be here for you in our family health team to help people in navigating the vaccine process in the next 6 months. So I'm going to pass it over to Naseem and just thank you for letting me join you.
Thank you so much, Linda and Karen, for being here with us. I will turn it over to my colleagues. I want to introduce our clinical nurse specialist, Sarah Nestico. Sarah, would you like to say hi? There's a wave from Sarah.
Yeah. Hi, everyone. My name is Sarah. I'm the clinical specialist, and I've been involved in some vaccine rollout, and I'm involved in communications along with Naseem.
So Sarah will be one of our speakers this evening, along with Brenda Chang, our clinical pharmacist. And Brenda, you can take it away and feel free to start the presentation.
Okay, great. Thank you, Naseem. So good evening, everyone. I'm Brenda Chang. I'm one of 3 clinical pharmacists here at our family health team. I cover specifically the 80 Bond Health Center site and the 61 Queen Family Practice site. So maybe some of you I've met in our paths. I will start the presentation, so just bear with me as I share my screen and we'll get to the meat of our talk today. Okay, so hopefully everyone can see that okay. Yep, I see some nods, that's good. So we'll get started. And again, this is really a talk about the COVID-19 vaccines. And again, as Naseem and Sarah and others have mentioned, this is our first town hall. So definitely excited to get this going, and hopefully we can answer a lot of the questions. I could see based on some of the chat comments and hands being raised that there are some questions already. And I do hope that I'm able to get through most of it in the presentation. But again, at the end, we will have some time for a Q&A period as well that Sarah and I can help to address as much as we can. So first off, I think you've already heard some of the introductions already, but I do want to acknowledge that Sarah and Naseem have been really instrumental in helping me plan this talk. Sarah will also be talking a little bit during the presentation around vaccine rollout and the progress to date. Naseem, towards the end, will also share some other talks that may be happening in the community that we can let you know about. And then my colleague Dorette Chang is not here today. I thought she would join us, but also want to acknowledge her because she did contribute to some of the slide deck information as well. If she does join us a little bit later, we would have an opportunity to have her join the panelists so she can help answer some questions as well. All right, so Naseem, I don't know if you want to continue to kind of review this a little bit with everyone.
Yeah, so I'll talk a little bit about this and I'll pass it right back to you, Brenda. So just to let everyone know, so you heard a sort of a notice right at the beginning there that the session was being recorded. So we are recording this session in order to have it available to folks and all of our patients after this session. And I wanted to invite everyone to use the Q&A function. So if you look at your screens, right at the bottom of your Zoom window, you should see several gray, they look like gray buttons, and one of them says mute, where you can mute yourself. There's a stop video. I think most of you are probably familiar with that. There we go. We've got a Q&A here from Diane. Thank you so much. So if everybody can open the Q&A, you can see that Diane has put something in there. And June, thank you so much. Yes, so we're going to ask that folks use the Q&A function because we have so many people on this call. It's a little bit challenging for us to get to everyone's question in a fair way unless we're using the Q&A function. So Sarah and I will kind of be working through that in the back end. If you do happen to put your question in chat, we'll try to get to that too. And I'm also noting that we have 3 people that have called in, and I see that one person already has a question there. So just encouraging everybody to kind of use the Q&A as much as possible, and we'll try to answer questions there. There's also a function in the Q&A, just so everybody knows, for you to vote for a question that you also want answered. So if you see somebody's asked a question that's also the question you have or related to it, or you really want to hear the answer to that one, you can upvote it and we'll see it quicker, so it'll kind of stay right at the top. So that's how we'll manage questions. If there are questions that we don't get to, again, the session is recorded. We're able to kind of download the chat, and we're going to do our best after this presentation to answer the questions and send them out by email. We may not be able to answer all the questions tonight. As most of you can see, we've already got a whole bunch. And as Brenda mentioned, we're going to have additional webinars posted at the end that our community partner organizations are hosting that you may want to attend. So we'll send that information. Out in the follow-up email. And the last thing I just want to mention is, for kind of future sessions, and just for your own knowledge, we are able to provide interpretation. We wanted to provide ASL interpretation for tonight, but we have noted in our planning that we have to have a specific accommodation request for that. So just letting folks know that if you do have accommodation requests, or if you want language interpretation, even though we are using virtual platforms, please do reach out to us and let us know. We're always happy to provide those services. And I think that's it from me. If Brenda, you'd like to take it away.
Okay, sure. And before I do, I just want to welcome Dorette, my colleague. I see that she's joined as a panelist. So welcome, Dorette. We acknowledged you earlier. So hopefully if you can stay for the Q&A period at the end, we'd like to be able to see you and help answer some of the questions that we might have. And as Nasim said, we do have the Q&A open now, so you'll be able to see questions that are coming up through. And thank you to Sarah and Nasim for keeping track of those, because sometimes there's so many. I do hope that the session will answer a lot of the questions based on my talk, so that we're not missing anything. And again, there will be an opportunity towards the end for a Q&A to address any questions that I may not have answered during the actual presentation part. And anything that's really outstanding, we do have the opportunity to send out some more information on email. So don't be too worried if we don't get to your specific questions, because there will be opportunities. And I think Dr. Wayman also highlighted in the chat that if you do have further questions, do not hesitate to contact your provider, whether it is your doctor, the nurse practitioner, or the nurses that you connect with regularly at the clinic. Feel free to connect with everyone within our family health team to answer your questions, or my colleagues Dorette and my other colleague John Hunchuk, who is another clinical pharmacist at our Sumac Creek and St. Lawrence site. Okay, so I'll get started. So very quickly, the outline for today's session is really to give you some information and key highlights about the current vaccines, as well as a little bit of information about the upcoming COVID-19 vaccines. I'll highlight some of the efficacy and safety of the mRNA vaccines, which are the current vaccines that we have now available to us, approved in Canada. I'll pass it over then to Sarah to talk a bit about the vaccine rollout and the progress to date. which is where she'll address some of the questions that I'm seeing that's coming up in the Q&A and the chat sessions. And then highlighting who should and who should not receive the vaccine. And again, that will probably address a lot of the questions that are coming up. There will be a section where I'll talk a lot about the common myths and the questions that we're hearing a lot of, either in media or just questions that are coming to our clinic from our patients. We'll highlight a little bit of helpful resources for everyone. And then towards the end, we'll open up the floor to a Q&A period. So that's the basic outline for today's session. So I'll start off with the key highlights around the current and upcoming COVID-19 vaccines. So to start off, what is the COVID-19 vaccine? So as you can see, the COVID-19 vaccine is really a vaccine that can help protect us from getting the SARS-CoV-2 virus. So that is the official name for the coronavirus, but we typically call it the coronavirus. And it is this virus that causes the COVID-19 infection. And it's important for us to receive the vaccine because COVID-19 as an infection or an illness does cause severe disease and potentially death in some cases, as you've heard in the news and in the media. So what we've currently got in terms of approved vaccine in Canada are two vaccines, one from Pfizer BioNTech, the other from Moderna, and they are both mRNA vaccines. So mRNA vaccines are messenger RNA vaccines. So essentially, the mRNA is a piece or a small strand of genetic material that is in the vaccine that helps to give us instructions or helps to give our cells instructions to make a protein that is on the surface of the coronavirus, and that is the spike protein. So that's how we recognize a piece of that virus and how we create immunity towards the virus. So the Pfizer BioNTech vaccine, as you can see here, is 2 doses. And I'm going to see if I can use a laser pointer so I can highlight what I'm talking about, is 2 doses, typically given 21 days apart. And the Moderna vaccine is 2 doses, typically given 28 days apart. Now, you've probably heard in the media that we've had some delays in shipment of vaccines, and we've had to delay some of the administration, particularly for the 2nd dose. And that is okay because we do have guidelines and information from experts telling us that up to 42 days is reasonable. So hopefully moving forward, we won't have more of these issues around vaccine supply, and we can follow the guidelines of the vaccine to be given in those timeframes that are highlighted. But certainly we do have information that can be given a little bit later if we need it to. So those are the 2 that we currently have approved. So how the mRNA vaccines work, I've kind of highlighted a little bit, but I'd like to walk everyone through the process of how the mRNA vaccines work. So here you can see it starts here with the injection, and we're shooting in particles into our blood with the vaccine particles. And as you can see here, these are all little tiny particles of the vaccine. And essentially the particles are we call them little nanoparticles, which is the piece of the genetic material, the mRNA, within a lipid layer or a little fatty layer that protects it, and that's injected into the blood. And once it goes into our bloodstreams, our cells, so the green particles you see here are our cells, they start to recognize it and use the material within that vaccine to build the spike proteins. So the spike proteins are the little red particles that are attached to our cells here. So we use that genetic material to help us build the spike protein within our body so that there's a piece of the virus material that we can recognize and start to build immunity towards it. After the mRNA is used to make that spike protein, it's dissolved. It's completely removed from our system and it doesn't stay in our body any longer. Our immune system then sees the spike proteins, and usually they're attached to our own cells, and triggers an alarm to sound the alarm for other cells in our body that helps to protect us from infection. So you'll see these other larger cells here that are saying sound the alarm, really recruiting all these other cells that would be protecting us from an infection to come and recognize this. And after we do recognize this, the immunity is built and we're sort of fighting off the infection, or what in this case is not really an infection, but sort of building an immunity and recognizing the spike protein is something that is not typically found in our body and is foreign. And we start to develop a response, and that response includes a fever and aches, just because we're building an immune response to that. And once that's done, you'll see that a lot of our cells will know how to recognize the spike protein that is there, the red particles. And when we do get introduced to the actual virus, so it's this blue particle here with the spike proteins, our body's cells can recognize this and fight off the infection. So in a nutshell, this is how the vaccines work. It allows our body to recognize the spike protein from the virus and then develop immunity and antibodies towards this. So I hope that makes some sense in terms of what the vaccine is doing. And of course, this is specific to mRNA vaccines, but a lot of our vaccines work in a very similar way in allowing our body to recognize what shouldn't be there and allowing us to recognize it so that we can build immunity and build antibodies to fight off the infection. So you might be thinking, well, what exactly is in the mRNA vaccine, besides that little piece of genetic material, the mRNA? So as I highlighted before, both vaccine, the Pfizer and the Moderna ones, do contain the genetic material, and it's the same genetic material of mRNA that codes for the spike protein. But in addition, there is a layer of lipids that surrounds the genetic material that's kind of protecting it in that little bubble. And you can see that there are cholesterol and other fatty layers in it that helps to protect that vaccine. And then there are salts, sugars, and buffers. The key thing to note is that the vaccine does not contain any eggs, gelatin, latex, or preservatives. And one particle of the fatty layer, or the lipid layer, is called polyethylene glycol. Now, the two vaccines don't have the same polyethylene glycol molecules, but they are very similar. And the reason I'm highlighting this is because later on, I will talk a little bit about allergies, and it's thought that potentially some people may be sensitive to this polyethylene glycol component. So I will review that in a little bit more detail in a second, but really to highlight that the mRNA vaccines actually don't have very much in them. It is just the genetic material, the mRNA, plus surrounded by some lipid layers of cholesterol, which we also have in our body, and some salt, sugars, and buffers. So are the vaccines religiously permissible? And the answer is yes. As I highlighted before in the earlier slide, there really isn't very much else in them. There are no pork-derived materials. There are no blood fractions or fetal cells used in the production. And the cholesterol and the lipid components are primarily plant-based or synthetic. So overall, it is described as permissible or recommended if there are any religious concerns. So that in a nutshell is what the mRNA vaccines are. So the Pfizer and the Moderna vaccines that are currently approved. Moving on, we do have some upcoming vaccines that have not yet been approved in Canada, but we will likely see them soon. So Health Canada has received submission for 3 more vaccines. 2 of the ones that are coming from AstraZeneca and Johnson & Johnson are called viral vector vaccines. And as you can see, I've also listed that both these vaccines have had their submissions go into Health Canada to be reviewed and approved as vaccines to be available in Canada before 2021. So AstraZeneca actually sent theirs in October, and the Johnson & Johnson one at the end of November. The AstraZeneca one is a 2-dose vaccine, and the Johnson & Johnson one is a 1-dose vaccine. So these 2 are viral vector vaccines, and viral vector vaccines basically use a safe virus to carry the genetic material of the coronavirus to teach our body how to recognize it and produce immunity. And what they're really carrying, again, is the genetic material to make the spike protein. So again, we are not injecting any live viruses or entire virus particles. They are just pieces of genetic material to train our body to recognize the spike protein. The third submission coming to Health, or has gone to Health Canada, is a protein-based vaccine. And that application went into Health Canada at the end of January 2021, and that's the Novavax vaccine. And it is a slightly different technology that's used to make this vaccine. It is a protein-based vaccine. And what protein-based vaccines are essentially, we sort of harvest proteins that are part of the coronavirus. And in this case, again, it's the spike protein. So in the vaccine development, we make lots of this spike protein, put it into the vaccine, and then adding along other proteins that may help boost our immune system or help us respond to the spike protein that we're actually injecting into ourselves better, we create this vaccine. So instead of the other ones where, you know, we rely on our cells to make the spike protein, in this case, we are injecting proteins into our bodies so that our cells can recognize these components. We also have some additional vaccines that have actually not yet gone to Health Canada as a submission, but we do have advanced purchase agreements for 2 other protein-based vaccine, and that's the Sanofi GlaxoSmithKline one and the Medicago one. So I won't go into any details of these. They haven't yet gone to Health Canada for submission for a review, but it is possible that these ones will come as well. So I'll touch base now on efficacy, what it means for the vaccines to be effective, and then the safety of the mRNA vaccines. And we'll talk a little bit about what the data shows in the studies, as well as what it really means in the real world. Like how does it look after we've started vaccinating people around the world? So to start us off, I want to review what is known as vaccine efficacy. You know, we talk a lot about, you know, it's 95% effective. Well, what does that really mean? So here's a diagram that helps you to understand what vaccine efficacy really means. So in this case here, you'll see that the top part is people who've received the vaccine. And so if 5 people receive the vaccine efficacy is 80% if 4 of those are protected and do not show infection, and 1 person ends up showing infection. So this would be 1 out of 5, or the same thing as 2 out of 10 people then being protected and not showing infection of any kind. That's what that means. And that is compared to people not receiving the vaccine at all, where they have no protection, and so they would all be able to get infection. So that is what we're looking at. So in the case of the efficacy for these mRNA vaccine, what we are reporting for the Pfizer vaccine is a 95% effectiveness rate or efficacy rate. And for the Moderna, it's almost the same, it's 94%. So you can imagine if you receive the vaccine, 95 out of 100 people would be protected from getting the COVID-19 infection or the coronavirus causing the infection. And similarly with Moderna. We do know that this information, you know, coming from the studies suggests that this number that you're seeing is based on receiving the second dose and after about a week to 2 weeks after receiving the second dose. So, you know, as soon as you receive it the next day, we're not seeing this kind of number. We're not saying it's 95% effective as soon as you receive it, but about a week to 2 weeks after, these are the numbers that we're seeing. We do have some information to say that after the first dose, so more than 14 days after the first dose, but before getting the second dose, the effectiveness rate or efficacy is about 92%. So what that really means is that there is good information to show us that even after 1 dose, we get fairly good protection. But of course, the studies looked at giving 2 full doses. So for the full protection of 94 or 95%, we do need to have both doses. So that's what that really means. And this is a bit of the busy information. This is data that actually comes from the clinical studies. And I'll highlight a few things. Really what I want all of us to understand is that these are graphs from the studies that really show, you know, over time on the bottom, the number of cases or cumulative cases of infection on this axis here, that if you get vaccinated, both for the Pfizer or the Moderna vaccine, your case, the cases that we're seeing of COVID-19 infection remains low. And if you don't get the vaccine, so here's the other arm of people who are in the placebo arm, who never got the actual vaccine, who got placebo, the number of cases of infection continue to rise. So if this seems a little bit complicated, I'll explain it in a little while. But another key aspect from the studies is that we could see by about day 12, you could really see that the curves start to separate. So if you were vaccinated, you will stay low in terms of getting an infection. So to simplify things, here's another way to look at it. So time on the bottom, COVID cases on the top. If you are in the vaccine group, the number of COVID cases remain low. If you are in the placebo group, you can see it skyrocket. So for sure, if you don't get the vaccine, you do not get protected. So that is basically what the clinical studies have shown, and we're reporting the effectiveness and the efficacy to you in that way. So what about in the real world? So that's based on the studies that were done and looking at the efficacy. So in the real world, this is some data that comes out of Israel, and I want to thank my colleague Dorette for sharing these slides with me. So looking at what happened in Israel in terms of the dates at the bottom and then their vaccine efforts. So you can see the vaccine starts in their effort to vaccinate everyone around December, second doses around early January. And the yellow line here are for all of those age 0 to 59, and the blue lines are those over age 60. The first graph that you see here, A, are new positive cases of COVID-19 infections. And then in this graph here, you see moderate to severe hospitalizations. And so based on the real world data of what's happening in Israel, where they've had lots of vaccinations given already, you can really see that after people have received the second dose, new positive cases start to decline. And it's particularly obvious for those over 60. And it's the same for the moderate to severe hospitalizations. You can see that the numbers start to decline. Now, it's not exactly the same for the younger age group, but still really important to highlight that there are differences in at least the number of positive cases here. So in the real world, there's definite differences, and this is based on a lot of vaccinations that's been given. So that's very important for us to know. And so how do these COVID-19 vaccines compare to our other vaccines that are out there? So here's some data to just show you, we give polio vaccines, we give what we call the MMR, the measles, mumps, and rubella vaccines that includes the measles. We also give the varicella vaccine, which protects us from chickenpox. So the Pfizer and Moderna vaccines actually are quite comparable to all of these vaccines that we give to our general population very regularly. So they do have very good efficacy and are definitely among the ranks of these vaccines. So just keep that in mind, that they are very effective. But of course, overall effectiveness depends on how many people get vaccinated. And I want to highlight some information here to really give you some perspective. The vaccine that you get yourself protects you, but overall effectiveness depends on the total number of people getting vaccinated. And here's the reason why. So at the top, you'll see here, the vaccinated person is in blue, and the infected person is in yellow. So if only a few people get vaccinated, you can see over time, the infected person mingles with more people, and over time, infection can still spread. But if a lot of people get vaccinated, so in this case here at the bottom, where lots of people are vaccinated, even if there's an infected person, that person is not able to spread the infection to other people. And we are able to protect more people that way. And this is the concept known as herd immunity. So it's really important for those who can receive the vaccine to receive vaccination for this reason. And obviously, with good uptake of the vaccine, we can eradicate disease. So here is, again, some data that comes from our Centers for Disease Control in the US that really talks about, compared to other diseases and our vaccine efforts, what's been happening in terms of reported cases. And this is some data coming out of 2019. So in the case of polio, you can see that the numbers are really low. And the reported case, so this is numbers reported in 2019, like paralytic polio is 0. So essentially it's 100% effective. There are no cases. And certainly, as you can see at the top here, the measles, pertussis, which is whooping cough, mumps, the cases are higher. And that's really a reflection of some vaccine hesitancy where some people are not getting vaccinated. Really important to highlight that if we stick with vaccinations, we are preventing disease. So that's it for me around effectiveness. And so now I'm going to go on to talk about side effects. And so what are the side effects, and are there any side effects? And of course, as with other vaccines like the flu vaccine, side effects can occur. So I don't want to sugarcoat it and say that there are absolutely no side effects, because with vaccination, there are often side effects. So what we observed in the clinical studies was that the side effects were usually mild to moderate and didn't pose any health risks. So they were not severe side effect or major side effect that needed to send patients to the hospital, etc. Most of the side effects also resolved within about 1 to 3 days of the vaccine. And there was some slight variability and some differences between the two vaccines, but overall still within about 1 to 3 days, the side effects would be gone. Overall, we also noted that the side effects were a bit more frequent with the second dose. So again, the Pfizer and Moderna vaccines need 2 doses, and we noticed that by the time you got your second one, the side effects was more noticeable. And we also know that actually for the people who were under 65, so the younger population who received the vaccine in those studies, tended to report more side effects. So the older participants in those studies actually didn't report as many side effects. So that's what we observed in the clinical studies. And so just to kind of highlight, some percentages and what it means. So for example, the very common side effects, and we usually call common side effects as those occurring more than 1 in 10 people. You can see that the pain, and so this is pain at the injection site, is the most prominent one for the Pfizer one, and it is the same for the Moderna one. Usually you'll get some tiredness, headache, some muscle aches, chills, and a little bit of fever. Same with the Moderna one, and the Moderna one also reported that some patients had a little bit enlarged lymph nodes. So, but again, these are not really, really big numbers with the exception of the pain, fatigue, and headaches. And as I highlighted before, in terms of how the mRNA vaccines work, we usually feel these symptoms because our body is building immunity. So that's really important to keep in mind, that it's because we're building a response, like our cells are moving in our bodies to really come to the area of where the vaccine happened and to recognize what is this foreign material that is in my body, and then building the antibodies to protect us. So that's why we get some side effects. But of course, there are some uncommon side effects, and in fact, large lymph nodes are more uncommon with the Pfizer, which is usually side effects in the 1 in 100. And then there are some rare side effects. So I've highlighted here the issue of anaphylaxis or severe allergic reactions. So these were reported, and the numbers here that you see here are the most recent numbers that we have around the incidence of anaphylaxis to these vaccines. So for the Pfizer vaccine, it's estimated to be about 5 in a million, and the Moderna vaccine is estimated to be about 2.5 in a million. So I'll give you some context about that in a second. So anaphylaxis is a severe allergic reaction, and as you can see here, it usually is a bunch of symptoms and not just developing a rash. That's usually not considered a severe allergic reaction or anaphylaxis. Anaphylaxis usually means that there's also some respiratory symptoms like cough, wheezing, trouble breathing, some skin reactions like hives or swelling of the tongue and the lips, as well as drops in blood pressure or even gastrointestinal symptoms. So a lot of these patients will then start to vomit, violent vomiting. It's because we recognize something that the body does not like and is allergic to, and we're trying to get rid of it. So that's usually what an anaphylactic reaction involves. And so for these types of severe allergic reactions and anaphylaxis, it occurs roughly about 5 to 30 minutes. In some instances, it may occur later, but for the most part, it occurs fairly quickly after getting, being exposed to, let's say, to peanuts, etc. And so I want to highlight that the incidence from the vaccines are a little bit higher than our typical vaccines. So for example, other vaccines, the incidence of anaphylaxis is usually about 1 in a million. And in the cases of the Pfizer and Moderna, it's about 5 to 2.5. So it is a little bit more, but it is still much less common than anaphylaxis to penicillin. We report the anaphylactic rate to penicillin at about 1 in 5,000 people. So really keep in mind, it's still really, really rare incidences. So just just to put that out there to let you know that it has been reported, but it's very, very rare. And we think that it may be linked to the polyethylene glycol component, but this hasn't actually been confirmed. And I want to highlight that polyethylene glycol is found in many things. So it's found in food, in cosmetic products, in a lot of our drug products. So if you've had like Advil liquid gels or Tylenol Easy tabs, those all have polyethylene glycol. And polyethylene glycol is actually also in some of our laxative products. So if you've had Restoralax, Laxaday, they all contain polyethylene glycol. There is some report that another chemical called polysorbate does cross-react with polyethylene glycol. So we really suggest that unless you've had confirmed allergies to these two components, the polyethylene glycol or polysorbate, that there's no reason that you can't receive these vaccines. And the Canadian Society of Allergy and Immunology have made that statement as well, that even if you have a history of severe allergy, let's say to peanuts, to bee stings, or other severe allergic reactions, you are not more likely to get an allergic reaction than the general population from these vaccines. So definitely safe for you to have. What we are recommending is that there's a waiting period that would be longer for you. So if you have had a severe allergic reaction, you would be offered a waiting period about 30 minutes at the vaccination site so that we can monitor you and support you in that way. And so what is the safety in Canada? So I think it's important, like what I've reported is based on clinical studies, and the incidences are often a lot based on the US data. So in Canada, Health Canada is tracking some of the adverse reactions that are reported to them. And as you can see here, this is data as of February 12th that is pulled from the Health Canada website around the vaccine safety and the tracking that Health Canada is doing. So as of February 12th, more than 1 million doses have been given. And the key point here is really to highlight that no safety signals have been identified by Health Canada. And the number of severe reactions or serious reactions, and serious usually means needing either to go to hospital, etc., is at 140. So it's really, really small based on the number of doses that we've given. Most of the other reports that are being reported here are actually very similar to what I presented earlier around people reporting that they're mostly getting pain at injection site, fatigue, but certainly we can report that to Health Canada. I myself, if I get the vaccine and I feel fatigue, I can report that to Health Canada too. So sometimes based on who is reporting, we may get a lot more numbers for certain things, but again, these are the total adverse event reports at 957 does include a lot of those that are more mild as well and not severe. So that's the safety issue around the 2 mRNA vaccines. And now I'm going to pass it over to Sarah to talk to you about vaccine rollout and progress.
Yes, so I see a lot of questions in the chat, so hopefully we'll get some of those answered. So we'll just talk about the rollout, where we are and where we're headed. If you could go to the next slide, Brenda. Okay, so progress so far. So we do know Canada has been behind in vaccine rollout. This just gives us a snapshot as of February 22nd. About 2.9 million or 2.9% of the population has received at least 1 dose, and about 1.5 million doses have been administered. Next slide. So when will you be able to receive your vaccine? So this is a really great picture that outlines the provincial plan. And just to reiterate, we are following the provincial guidelines on vaccine rollout. They have divided their plan into 3 phases and given some timelines. So I'll just review that, and it'll be important to know where you might sit in these timelines to understand when you may become eligible for the vaccine. So we're currently still in phase 1, and we anticipate being in phase 1 until the end of March. So phase 1 includes seniors, those who live in congregate settings, nursing home, long-term care, retirement homes, those over the age of 80, healthcare workers. These healthcare workers are those who have mostly direct contact with patients and clients, adults in First Nations, Métis, and Inuit populations, and adults who receive chronic home care. Phase 2, which we hope to to enter into in the spring, which will commence April to July, that's when it'll start to get opened up to essential care workers. And this will include people who work in frontline industries, so teachers, those who work in schools, those who work in manufacturing, those types of jobs, but also it'll include people who have chronic conditions. So that could include diabetes, COPD, and then it'll also we'll start to break down populations by age category. So it'll be 75 to 80, and then 70 to 75, and going down by 5-year increments. And then by August, we hope to have really great supply of vaccines, and it'll be open to every Ontarian. So the other part of this is just understanding how vaccines are being delivered. And so right now, the main way that vaccines are going to be delivered are through large hospital mass vaccination clinics. So we have those set up at many hospitals, and throughout the city and public health units, they're setting up mass vaccination clinics basically as we speak, and they're ready to go once they have supply. So particularly people who are in phase 1, who will be the next in line for vaccines, we do anticipate that you will be asked to go to one of these larger vaccine centers. We are hoping that come phase 2 into April and into the summer, we could start to see vaccines being delivered and administered in primary care and pharmacies, similarly to how we receive a lot of other vaccines, so like the flu shot, for example. But that's going to depend on vaccine supply, similarly to what Brenda was mentioning before. With the newer vaccines that we hope will be approved, they have greater potential for being stored in regular storage fridges and will become more accessible in primary care, but we're not exactly at that point yet. And then there's mobile outreach that is happening. So depending on where you live, and you might be eligible for a mobile outreach, and this is where the pop-up clinics are happening. And this is a lot for long-term care homes, shelters, congregate living centers, seniors care centers, and that's how vaccines have been delivered. So just understanding where you fit may give you an idea as to when you'll become eligible for receiving the vaccine. We could go to the next slide. So we're still in phase 1, but we're kind of in the latter half of phase 1. So as many of you have likely heard, next on the list is adults 80 years of age and older. This also includes staff and residents in long-term care homes who haven't been vaccinated, healthcare workers in high priority groups, Indigenous adults, and recipients of chronic home care. So we do know that there has been the call out for adults 80 years of age and older. But we do have to say right now, we do anticipate that you will be asked to book a vaccine at one of these larger vaccination centers. Actually, Brenda, we could go to the next slide. So where can you receive the vaccine? If you're in this group, you're likely going to go to a mass vaccination clinic, and you'll likely be asked to book an appointment. We're also quite hopeful that those who are already receiving home care will get connected through their coordinators. So if you are a patient or you have a family member, pay particular attention and maybe connect with your home care coordinator in the coming weeks. But right now, we're still waiting on direction from the province as to how appointments are going to be booked. So what are we going to be doing as a family health team? So at present, we're not offering vaccines in our clinics. We do hope that that will change, and we'll let you know as when it does. But our role is really going to be about connecting you to where and how you can book your vaccine once you become eligible. So please continue to check our emails and our website for updates. We will be getting in touch. If you are in this age category of over 80, just know that we do have access to know how many patients fall in this category. And internally within our department, we're looking at creating mechanisms to ensure that we can support support each of you once we have further direction. And the next slide just reinforce, yeah, that's perfect. So just stay tuned for your emails and the website.
Great, thank you, Sarah. So I'm going to continue on to sort of highlight who should and should not get the vaccine. Hopefully Sarah's update around vaccine rollout answered a lot of the questions that we're seeing on the Q&A already. But certainly we can try to help alleviate some of the anxiety around when you can get the vaccine a little bit later in our Q&A session if we have time to do that. So in terms of who should and should not receive the vaccine, I'm just going to highlight a few things. So the vaccines have been authorized for specific age groups, and that's because they were studied a certain way. So you can see for the Pfizer vaccine, the authorized age is for anyone over the age of 16, and for the Moderna vaccine is anyone over the age of 18. And from the studies that were done, you could see here that the researchers did include a large number of participants as well as a wide range of ages. So it's not all studied in young population. There were definitely a lot that were in the older age category. They also included very diverse backgrounds. It wasn't one specific country where it was very like a pocket of participants only. Lots of different people with a different ethnicity and races were included. There were also some stable HIV patients, hepatitis B, hepatitis C patients or participants, included in the study. And for the Moderna study, there were participants with lung disease, asthma, cardiac disease, diabetes, liver disease, and HIV included. So just to really give you a sense that lots of different people were included. So who should really not get the vaccine? There are really only two main reasons you should not receive the vaccine. And one is if you're not in the authorized age group. So in the case of the Pfizer, if you are under the age of 16, and for the Moderna, if you're under the age of 18. And the second is if you've had a previously severe or immediate alert to any ingredient in the mRNA vaccines. So if you already know you have an allergic reaction to polyethylene glycol, that may be of concern. Right? So it's really those conditions. As a precautionary measure, though, we do ask people who are acutely ill to defer their vaccine until they've recovered. So meaning if you are not well, you should not be going to a vaccine site, because in the event that you have COVID-19, you could be passing it to other people at the vaccine site. And we are also asking people who've received a vaccine, other vaccines, like let's say you've got the shingles vaccine or any other vaccine recently, that it may be best to wait at least 14 days after you've received those vaccines before you get the COVID-19 vaccine. And that's mainly to prevent us from getting confused. Like if you're having a reaction, is it because of the other vaccine you just received or the COVID-19 vaccine? So to make it easier for us to help manage your symptoms as well, that's what we're recommending. So what about pregnancy and breastfeeding? So the current mRNA vaccines were not tested on pregnant or breastfeeding women, although research is now being done in these populations, and you may have heard that in the media. What we're saying now is pregnant and breastfeeding women may receive the vaccine if they choose, but they should do so after discussion with their healthcare provider. And due to uncertainty and really not having enough information around the vaccines, public health officials are suggesting that if you've received the vaccine, that you should try to avoid getting pregnant within 28 days of the last dose. The Society of Obstetrics and Gynecologists of Canada do state that the documented risk of not getting the COVID-19 vaccine outweighs the potential risk of being vaccinated, and so the vaccine should be offered. And in the case in Ontario, a verbal attestation or a verbal consent has to be documented before the vaccine is offered to a pregnant individual, and that should be done with your healthcare provider. So what about children? So I did highlight before that the two vaccines were not studied in younger individuals. So for children and adolescents, they were not included. However, there were a few individuals aged 12 to 15 that were included in the Pfizer-BioNTech trials, but the numbers were very small. And so the vaccines were authorized only to be given in those over 16 for that reason, because we just don't have a lot of data. The Ministry of Health suggests that the vaccine may be offered to those aged 12 to 15 who are at very high risk of severe outcomes of COVID-19 infection and or have an increased exposure. So that may mean the people in that age group who are living in certain homes where other people may be exposed or have a lot of medical and health concerns, where they would be at really high risk of getting severe disease or illness from COVID-19. So this age group may potentially get the vaccine. And again, it requires informed consent with the individual or the parent or guardian and their healthcare provider for the vaccine. I did see in the chat lots of questions or in the Q&A around immunosuppression, autoimmune diseases, etc. So in the event that you have an autoimmune condition, or if you are immunocompromised due to a disease or medication, we are still suggesting that you may receive the vaccine, but that you should do so after your discussion with your healthcare provider. So there were some individuals, like I highlighted in the earlier slides around the Pfizer and Moderna trials, where some immunocompromised states were included, but we just don't have lots of numbers to be confident and make strong recommendations for these individuals. So the other issue is that there's the possibility that the vaccine effectiveness might not be as good if you're on immunosuppressive therapies or medications that suppress your immune system. So that could happen. So we just don't have a lot of confidence in that. But there's no information to say that you should not receive the vaccine. And again, depending on the circumstance, you may have to give a verbal attestation or verbal consent in order to receive these vaccines. So that's it in terms of the special population. So now I want to spend some time highlighting some common myths and questions, and then hopefully after that we can get to some of the Q&A. So in terms of common myths and questions, so obviously you may have heard a lot either in the media or social media. There are sometimes a lot of myths to dispel, and hopefully with the next set of slides that I can answer most of the questions and give you some confidence in the COVID-19 vaccines that we currently have. So the first question that's come up is, were the vaccines rushed in development in any way? Like, how did we get them so quickly? So I want to highlight that no steps were skipped in the development. In fact, the experiments that were done, or the research that was done for these two vaccines, were actually very large, roughly about 10 times larger than previous vaccine trials that we had. So typically vaccines trial would include about 6,000, 7,000. For the Pfizer vaccine, there were over 40,000 participants, and the Moderna vaccine had over 30,000 participants. You know, what really made the vaccine approval process so fast were a couple of things. One was that the timeline was shortened by overlapping some phases of the clinical trials. So you'll see here this graphic here that highlights, basically how we develop vaccines is that first there's some animal studies, which we call preclinical trials, that happen. And then the clinical trials that happen in humans usually occur one after another. Phase 1 first for about 20 to 100 people or so, so usually in the tens. Then phase 2 happens for hundreds of people, and phase 2, so phase 1 mainly looks at safety, phase 2 mainly looks at efficacy and safety, and then we get into phase 3, which is really looking at how effective the vaccine or the drug is, and that's in the thousands. And normally it happens one after another. And in the case of these COVID-19 vaccines, we enrolled participants in these phases all at the same time, and we carried out all the trials at the same time so that we could speed up the process. And then there's the phase 4, which is the review and approval process. And our federal health minister did sign an interim order that allowed Health Canada to accept submissions from these drug companies to send in information about their vaccines early, even though it wasn't finalized, so that we could review it faster. And so that's one of the reasons why the approval process of these vaccines happened so quickly. So nothing was really skipped. There was nothing that was rushed through to make sure that we approved these earlier. So I hope that helps to alleviate some stress around why did we get them so quickly. The other question is, will the vaccine merge with my DNA? So the answer to that is no. The mRNA vaccines do not affect or interact with our DNA in any way. In fact, they don't enter the nucleus of our cells where our DNA is. So we have cells, and then within our cells, we have the nucleus, and our DNA is within the nucleus. So the mRNA vaccines never make it there. They do enter our cells, and we use materials within our cells to translate the mRNA called ribosomes that build the protein, the spike protein. And then after we translate that mRNA to make the spike protein, we naturally get rid of it. We break it down, it's dissolved, and we get rid of it. Enzymes destroy it, and it doesn't stay in our body for long. So there's no lasting effect, does not affect our DNA in any way. Another question we typically get is, do the mRNA vaccines have dangerous ingredients? So the answer is no. They don't contain any mercury, formaldehyde, aluminum, egg or fetal cells. Some of that I highlighted earlier. But in our vaccine process, so here's a picture that shows you what's usually in a vaccine. So usually in a vaccine, there's the active ingredient, there's water, there may be some preservatives and stabilizers. And in the case of the mRNA vaccines, we actually don't have any preservatives. And that's one of the reasons why we need super cold storage to make sure that they're still effective by the time we need to use them. Sometimes there may be some residual traces of things that was used in the development process. And that's where some of the concerns around formaldehyde comes in, although the mRNA vaccines actually don't have any of those. And then there are other things called adjuvants. So these are usually protein particles that boost an immune response. And the mRNA vaccines actually don't have any of this. The ones that are coming later, the protein-based vaccines, may have some adjuvants added to really help us boost our immune response. But at this time, the mRNA vaccines do not have any of these. Like I said before, it's mainly salts, sugar, water, the mRNA itself, and then encased in a fatty layer so that we can inject it. One concern is that we don't have long-term safety data information. So how do we know the vaccine is safe? So to date, I just want to highlight and share some data here to really show you all around the world. There has been millions of doses given, and obviously Israel's in the lead here with lots of vaccine doses being offered already. Lots of people have received them. As a reminder, the vaccine particles are broken down very quickly and removed from the body once we receive the vaccine, and so is our initial immune response. So that achy feeling, the fatigue that you might get, that happens shortly after you receive the vaccine, and that's our immune response. And after that, our immune system subsides and goes back to the way that it was, and none of that continues to happen. So what we're really waiting for now is information on how long the vaccines protect us for and whether we need booster doses in the future. So the clinical studies that were done collected data primarily over about a 2-month period. And really after 2 months, you could really see the benefits of getting to be on the people who received vaccine versus the people who didn't get it and was on the placebo side based on the curve that we showed you. And so they felt confident to show you that it's very effective, and the side effects reported, I already highlighted, mostly mild to moderate. So we have that data. So moving forward, we are collecting more data on, does it protect us longer, and do we need booster doses? So just be aware that that's what we've got, and lots of people have received the doses, so we're fairly confident that they are safe. Another question is, will I get COVID-19 from the vaccine? So the answer is no. The mRNA vaccines cannot produce the infection because only the spike protein is being produced. So there's no replication of viruses in our body to produce infection. The mRNA vaccines are also not live virus vaccines. So we do have some of those, but mRNA vaccines are not live virus vaccines. So there's no way for any replication to occur. Can I still get COVID-19 after I get the vaccine? So this is a good question. So vaccinated individuals can still be infected. For one, it's not 100% effective. So I highlighted before, it's about 95% effective. And you did see on the curve that the curve did go up slightly. So it's not 100% effective. However, vaccination does greatly reduce your risk of infection and reduces the risk of infection progressing to really severe disease, right? We don't want people going to the ICU, getting really sick. And so for anyone with an active infection, we do suggest that you wait until you are well without any symptoms before getting the vaccine to avoid transmitting the virus at the vaccine sites. But it is not 100% effective, so you may still, but it's a good chance that you'll be protected from it because of how effective it is. I already had COVID-19. Do I still need the vaccine? So the answer is yes. Even if you've had COVID-19, it is not known how long the antibodies you develop naturally to an infection will last. And we have seen some cases of reinfections. And so that's really important for everyone to know, that even if you've had infection, that you should still go and get your vaccine. Keep in mind that you should get the vaccine to protect yourself and others after you recover from the infection, because there are some people who cannot yet receive the vaccine. So for example, the children, they don't have the opportunity to receive the vaccine. So it's important for you to get vaccinated so that we can be sure that you have good protection, even if you've had COVID-19 already, so that you can protect the others and not transmit infection in any way. So which leads to the next question of, do the vaccines really prevent transmission of the virus? So at this time, we don't know if the vaccine protects against mild or asymptomatic infections, or infections that don't have any symptoms, because the studies that were done by Pfizer and Moderna really looked at whether the patients showed symptoms about 1 to 2 weeks after they received the vaccine. So symptoms of COVID-19. So they never looked at people who had no symptoms and just tested them to see if they had COVID-19 anyways. So it's possible that someone who has been vaccinated may become infected without showing any symptoms and transmit the disease unknowingly. And since the protective effect is not 100%, we need to still follow all public health guidelines for social distancing, masking, frequent hand washing, etc., until we really know more. Okay, so some of these guidelines will change in terms of how we need to protect ourselves, but very important to still stay protected. And then another question is, can I stop wearing a mask after my first injection? And the answer is no, because we've highlighted already before that full immunity occurs about 1 to 2 weeks after the second injection. And a few individuals may still get infected. So please continue to follow current public health guidelines. And I did see in the Q&A and the chats asking about, are there some differences between the vaccines? So right now, there are no studies comparing the two mRNA vaccines. Both vaccines are about 95% effective. In terms of the newer ones that are to come, which we haven't yet approved, the viral vector vaccine's effectiveness is about 70%, and the protein-based ones are about 90%. So slight differences in the exact number for the effectiveness, but I want to highlight that all of these vaccines are still considered effective. And the reason is because 70% effectiveness is still better than 0% effectiveness. So when we're thinking about getting a vaccine, that's really important. And even in terms of our annual flu vaccine, sometimes it's not 100% with our flu vaccine either, but we recommend everyone to receive it in order to prevent transmission and infecting others, and really to prevent those who would get very sick from getting the virus. So that's very important for us to keep in mind. And of course, there's a lot of talk about the new strains that are out there. So will the vaccines work on these new strains? So we are now calling the new strains variants of concern. And of course, the three main ones are the B117, which is known as the UK strain, the B1351, the South African strain, and then another one coming out of Brazil. So both of the Pfizer and Moderna researchers are looking into whether these vaccines will continue to work on the new strains. So far, there's no evidence that shows that the vaccines will not work. However, what they have found is that the amount of neutralizing antibodies produced may be slightly less for the South African variant for both vaccines, but the amount that's produced is still at a protective level. What that really means is that the researchers now need to look at whether booster doses will be needed in the future to improve the immunity, because the amount of antibodies is not as high as if they were exposed to the usual strain. And I just want to highlight, the spike protein is actually a very large protein. And so a lot of mutations need to happen in the virus to change the spike protein in such a way that we wouldn't be able to recognize it at all after the vaccine and to render it completely ineffective. So at this time, we don't have any information to say that they will not work. So keep that in mind, that we still are confident in that. And earlier on, when the vaccines first came out, there was some concerns around Bell's palsy or facial paralysis. Does the vaccines cause that? Is it true? So a few cases were reported, but I want to highlight that the incidence of Bell's palsy was reported from those clinical studies were about 18 in 100,000, which is about the same incidence that you would expect in the general population anyways. So the vaccines do not increase your risk, and anyone with a previous history of Bell's palsy can still get the vaccine. And finally, will the vaccines affect my fertility? So there is no scientific basis for the claim that the vaccines impact fertility in men or women. There is also no evidence to support the claim that the vaccine can cause erectile dysfunction in men. And really, on the contrary, there's some evidence linking the COVID-19 disease itself may increase suffering from erectile dysfunction, because oftentimes when someone develops severe illness from COVID-19, other systems in the body may be affected, such as their blood vessels, etc. So those things may have an impact overall on sexual function. So that's really important to keep in mind. So that's it in terms of the common myths and questions. I want to spend just maybe 5 minutes on resources and then passing it on to Naseem. And then we'll go into the Q&A. So in terms of resources, Women's College Hospital does have some resources in different languages. So if you need to access these, we also have links to this within our website. So if you need that, you can access that. Of course, to highlight, our website is very helpful. And of course, you can access the Government of Canada, Government of Ontario, and Toronto Public Health websites for more COVID-19 vaccine information. And I'll just pass it over now to Naseem to highlight a few upcoming events.
Sure. So really just this slide is to let folks know that we're not the only ones doing this work. So there's lots of our community partners that are also wanting to share this information. And some of these events are more specific. So I actually saw a question around mental health and the vaccine and mental health and COVID-19. So the person that asked that question might be interested in this upcoming webinar on Monday. Mental health problems and the consequences of COVID-19. And there were some webinars that were being hosted kind of all through February around COVID-19 vaccinations in the Black community. So unfortunately, many of those have already happened, but there is one coming up on March 6th as well. And that one is around Black health professionals, risks and resiliencies in the pandemic. We are going to send information for these webinars out to everybody, along with the link to the recording for today's session and the resources that Brenda just shared. So those web pages that we kind of recommend that you get your information from. And I think that's it from me in terms of community information and events. As we said, we'll continue to share with you by email anything that we think would be really good information for our patients to know, or events that we may think that you want to access. I think we can go into the question and answer period now, if that's okay.
Okay, great. Thanks, Naseem. Sorry, I'm losing track of time. So maybe you guys can let me know how much time we've got remaining.
So we've got 19 minutes.
Okay.
We're gonna end right at 8 and let folks kind of continue with their evening. We should go to just to let folks know, we have 89 questions open. So a bunch of them are similar. We'll try to kind of theme them and get to them as best we can. And like we said earlier, those that we don't get to, we'll try to send out information afterward.
Okay, awesome. So really, in summary, we encourage everyone who can get the vaccine to get vaccinated when it's your turn. And in the meantime, continue to follow the public health measures. And once you receive your vaccine, share it with others. Let other people know that you've received the vaccine. So that's me getting my vaccine. Because that's important. So we'll move on to the question and answer period now. I'm happy to stop share so that they can see us better. Is that okay?
Sure. Yeah, that sounds great.
Okay.
Yeah, thank you, Brenda. We really just, our main goal is really to just help folks make an informed choice and get the vaccine. There were quite a lot of questions. Perhaps Sarah, you want to speak to this about rollout. So any kind of specific information we have around chronic conditions. So it seems like a few folks wanted to know about those who are under 60, or maybe we should say under 80, because there were a number of questions around this, who live with a chronic condition, and any specifics you can share around the phases of rollout.
Yeah, those are all really great questions. And I believe we can anticipate that come the spring, that's when this particular group will start to get vaccinated, which is actually really great because it gives us this next month to vaccinate the over 80s. It gives us some time to open these larger vaccination centers to really get that flow going. And by then the information will be readily available to people. So we'll already know the booking process. And so all of that information will already be available. If you're interested in kind of understanding, you know, I've seen a few questions on like, what vaccine am I going to get? Will I be able to choose? And that's likely, you're likely not going to be able to choose this specific vaccine. It's going to depend on where you're going to get vaccinated. So it's good to be familiar because with your local public health website. So people who live in the city of Toronto, public health units are really going to be leading a lot of this population-based vaccination program. So you could go to, and we've linked Toronto Public Health on our website. So you could go to their website. They've already listed out where their vaccine centers are going to be located. They've also listed out their consent form. So that's an important thing to understand, is that you will have to fill out some questions before you get vaccinated. It's just going to ask you some simple questions. Just make sure that you don't have any potential contraindications, so reasons why you wouldn't be eligible for the vaccine if you had any allergies, and then you're going to consent to receiving the vaccine. At that point, you're going to know which vaccine you're getting, and you're also going to be getting a record of vaccination. So you're going to be leaving your appointment with a record of your vaccine. So all of that information is being tracked, or is being entered into a universal provincial platform. So that's kind of what's taking a little bit of time, is we need to track these vaccines, and we also need to make sure that we're getting them out to the right people, and we want to make sure that everyone's vaccinated.
So I think kind of related to that question, there were some questions around the portal opening on March 15th. You know, we might not be the best folks to answer this, but we can give it a shot. Just in terms of like coping with everybody kind of trying to access at the same time. Yeah. And there were also some questions in the chat around our fit specifically, like are we going to be able to support folks that you know, may not have the technical skills to sign up?
Yeah, that's another really great question. So we encourage everyone who can to become familiar and just pay attention. The truth is, yeah, we don't have the answer right now, but we do think that the answers are coming. So we're going to keep you updated. So just stay up to date with the information we're sharing. If you can book your own appointment, we're going to encourage everyone to do that. We do recognize that people are going to need some additional help, and that's why we are going to look at some mechanisms in our department to help support those patients. For now, please avoid calling in to ask any questions about booking an appointment. If you have a question related to vaccines and you want to talk to your doctor, please feel free to call and book a telephone visit. But we're not collecting names, and we're not creating lists right now. So once we have that information, we're going to send it out, and we'll be looking at making sure that we can still manage our phone lines and have a clear pathway for people who have questions, and we can give them clear answers once we know more.
And again, kind of on the same theme around essential workers. So Paul, I see you've asked this question. I want to say also that, again, we may not be the best folks as the family health team to answer this question, because I absolutely agree with you, Paul. I think people that are working at food banks are certainly considered essential workers. Yeah. But I think the question is just around, you know, if we can give some more information about what essential workers are, and are these folks being prioritized, and what that would look like in terms of rollout.
So on the government website right now, they've listed essential workers, which could include first responders, educational workers, and food processing industries. They haven't really gone into too much detail, but I do anticipate that there will be more details. Right now, the real focus is getting that next group of phase 1. And I'm sure that we'll start to see more clear guidelines around those with chronic conditions and their care workers and who is a first responder and what does that entail. So more information to come.
Thanks, Sarah. We've had a couple questions here about how long the vaccine lasts, and are we to expect to get vaccinated every year? Is this something that we would look at once and then a booster? Like what should we expect?
So maybe I'll take a stab at that. So at this point, we actually don't know because we don't have long-term data to know how long our immunity lasts for. So it is a very good question whether it will be similar to our flu vaccine, where every year we would need a dose. There is some difference between the coronavirus and the flu virus. Of course, there's a lot of changes that happen with the flu virus, that every year a different vaccine is produced so that we can capture it better and make sure that we develop immunity. At this point, we don't know if that's the case. Boosters are usually needed when we start to notice that our immune system doesn't produce as much antibodies as we would like it to give us the protection. So sometimes boosters are needed several years out. And again, at this time, it's a bit early for us to know whether we need the boosters. So for now, I would say stay tuned. I think the most important thing is to get the first vaccine, both doses, to protect yourself and the others, especially the people around you who cannot receive vaccines. And then we'll wait to hear more both from like the researchers as well as in the real world, because like in the case of Israel, once vaccines are being given, other researchers will start to collect data on what's happening in the real world, what's the protection like, and we'll be able to provide more information. But at this point, it's a bit too early.
Thank you, Brenda. We also have a question here. It seems a lot of folks want to know if we have any information on COVID passports for travel purposes. So again, I don't know if anyone here wants to take a stab at that. We might not be the best folks here at the Family Health team to answer this one.
I can jump in that I don't think that there's been any messaging to us in terms of the plans for that at this point. I know there's debate about that in terms of whether that's coming. So I think we're all in the same boat in terms of watching to see what the messaging will be from the government on that one.
Thanks, Linda. We have a great question here from Donald, just wondering about what's happening in Toronto around clinical research. So Donald has let us know that Duke University is testing Pfizer's vaccine on 2,000 children between 12 and 15. So are we aware of anything like this happening in Toronto?
Maybe I'll start, and then if Dr. Wayman or Sarah want to jump in, certainly you can. So I'm not aware of any specific clinical trials that are being done in Toronto specifically around, let's say, specific populations like children, etc. But there are definitely research being done in those areas where, you know, I talked a bit about pregnant populations before, and children are being looked at, but maybe not specifically within our local area. There is some research being done around vaccine development in our local area. So I didn't highlight this in the beginning, but what I highlighted was that we have 7 vaccines with advanced purchase agreements, 2 approved, 3 coming. But in the overall landscape of COVID vaccines, there are actually hundreds, a lot of them. And there are researchers in Toronto even looking at developing vaccines. So there are certainly research in different areas, but I can't really speak to specific populations being looked at within the Toronto area.
Thank you, Brenda. We have one actually from the chat that I think might be nice for us to address. So Angelita is asking, I heard you're to sign a form before your vaccination, and does this form include any of your health information?
So this form is similar to when you get a flu vaccine. So it asks you just some pre-screening questions. So it's not going to ask some in-depth background health information. It's basically going to ask you, do you have any symptoms of COVID-19? Do you have any allergies to anything in the vaccine? And then, are you immunocompromised, pregnant, or breastfeeding? And then, do you consent to the vaccine? So it's probably about 8 questions that you will complete prior to, but it's not going to ask you for in-depth health information.
Okay, great. Thank you, Sarah. We have a question here around some information, some research that came out of the UK that was indicating that many patients that had a BMI over 35 needed ICU care. So the question is just around, are there any considerations around folks that have a high BMI for prioritizing in terms of the vaccination?
I'm not sure, Brent. I don't believe that that's included right now. There is the main priorities are a lot of it has to do with age and also where people live and work. Those are like kind of the big cohorts for prioritization that you'll see in phase 1 and 2. I mean, I guess things potentially could change, but currently right now, we don't see that as a prioritization.
Great, thank
And
you.
I'll just, sorry, I was just going to add, yeah, agree with Sarah. We don't have that information. I think most of the data that's coming out now have given us the sense that the older population, be it whether they are healthy or not, age is really an important factor in terms of getting very sick from COVID-19. So that's one of the reasons why age has been prioritized, and certainly the other high risk individuals identified is on the high priority list for that reason. BMI at this point hasn't been identified, but keeping in mind that potentially that these people may also have other chronic conditions. So if that is the case, they will certainly be in the phase 2 and not within our regular population, which may come actually in phase 3. So at this time, we might have to stay tuned as more research is done to kind of highlight which are really the at-risk groups. But age is certainly one big factor at this point.
Thank you, Brenda. So there are a couple questions around, Sarah, you've addressed this already. I don't know if you want to speak to it again. Just is it possible for folks to choose which vaccine to get, or perhaps delay their vaccine dose because they may prefer a specific vaccine?
Yeah, that's a great question. I think we would encourage everyone to get their vaccine when they're eligible. Just recognizing that this is, this is one of the ways we get out of this pandemic, is getting everyone vaccinated as soon as possible. So would encourage people to take that opportunity when it becomes available, recognizing that these are all really great options and great vaccines. If it comes down to more around access and accessibility, that's completely understandable. I think we'll know more in the coming months as to if we'll see more vaccines in community, including our offices. And as we do, and when we do, we can kind of look at ensuring that there's like some equity involved in ensuring that we can get the vaccines to the right people in the right ways, and making sure that we're being thoughtful about it.
Thanks, Sarah. So we do have a question here around the difference between the 2-dose vaccines and the Johnson & Johnson single-dose vaccine. And are there any disadvantages to the single dose? And if we could share some information about that.
So thank you for that question. I think the key difference is really that the Johnson & Johnson single dose vaccine is not an mRNA vaccine. It is a viral vector vaccine, which I highlighted before. Specifically why it was formulated to be only 1 dose is really based on the research being done by the manufacturers. So it's hard to highlight to say specifically that the 1-dose vaccine is any less better than the other ones. Based on the data that has come out, preliminary data that's come out now so far, based on what we know about those vaccines, is that the efficacy from that one is roughly about 65 to 70%. So it is slightly different from our mRNA vaccines. But again, like I said before, you know, all of these vaccines are actually considered effective when you look at the effectiveness rates, because without vaccine it would be 0%. So there is really some differences in that. Now, I don't have information around, let's say, the side effect profile of those, because none of that information has been published in detail for us to review. But at this time, there is some information about how well they work, and that's already posted, and it is slightly different from the mRNA vaccines.
Maybe one last question, where we're nearing the end here and losing some folks. So maybe I'll ask this one to the group, and just I'll say, folks, there are a whole bunch of questions just around like specific health conditions and specific medications, and we do recommend that you speak with your doctor or your provider or someone on your care team about that. They would be the best to give you the best answer that's kind of specific to your situation. The one question, though, I think that's here that we can maybe end off with is, do you anticipate that when the vaccine becomes widely available that you'll offer it at your clinics? And if yes, will you be contacting us?
Yes. Well, if once yes to both. So once we get the green light to go ahead with administering vaccines, we'll likely administer them similarly to how we do a flu clinic every year. So once we know more, this is why just pay attention to our email updates and on our websites, and we're going to be updating those regularly. So check there first before calling in. That might help save some wait time on the phones.
Thank you, Sarah. And we're just nearing 8 o'clock now. So I think we're going to wrap up. I want to truly and sincerely thank every single one of you that joined this call. You know, I think the most exciting part for us was the question and answer period. You know, so please don't hesitate to reach out to us, to reach out to your care team. You know, I think we really do enjoy these conversations and connecting with all of you folks. We had about 380 people at Max today. So again, thank you so much. And we will send out a follow-up email with all the information that we mentioned. I'm seeing lots and lots of nice comments in the chat thanking us, but truly we thank all of you for being here and engaging with us. So I think we'll wrap up and say goodbye. And if anyone else wanted to say goodbye, please feel free. Take care, folks. Have a great evening.
Good night.
Team, great work.
Yeah.